as well. Natalie's joined us. Now, Natalie's on this afternoon with Paul Corris talking about the surgical interventions in PH. So Natalie is nurse specialist, just retired. Can we say retired? Just retired from Patworth after. Again, you've been around as long as me and Wendy, really, haven't you? Yeah. So, welcome, Natalie. And Patworth, has Patworth moved this week? Just out of interest, is it? Get the mic.
Patworth moved the entire hospital last week.
Did it?
So I've been talking to some of my erstwhile colleagues, and to say that they're stressed is putting it mildly. So if you are a Patworth patient, please cut them a little slack.
So first question. Can we play the first question? Oh.
Is it guess who?
No.
Time, I find I'm okay, but if occasionally I do things too quickly, I tend to panic. What's the best way to deal with panic, with breathlessness when I panic?
Okay, Natalie, can I come to you on this one? So this is somebody
thanks very much.
Who said, the first bit, she said most of the time she's fine is when she gets breathless. There's this panic circle, this sort of magic circle of panic just builds in.
Yeah. Panic is quite common, I think, that moment when you actually are wondering if you're going to get your breath back. I think there's a few things. First of all, before you start the activity, it's important to remember that people don't die of breathlessness. It just doesn't happen. You can feel absolutely panicked out of your mind, but you're not going to die at that moment. You're really not. So I think it's a question of preparing your activity, whatever it is. If you know that this is something that's caused you a problem before, then obviously as many strategies as you can put in place to make it as easy as possible for you as you go along. But the panic might not be a consequence particularly of the physical manifestation of the disease. It might be a consequence of deep-seated anxiety anyway. So under those circumstances, I would absolutely advise that you speak to either the specialist centre or, to be honest with you, a GP. Pulmonary Hypertension Association has this great programme with Anxiety UK. So if you need some kind of help, some strategies to help you to deal with situations if you are prone to panic attacks, then that would be a good place to start.
The only other thing that I would add to that is to practice good breathing techniques and sort of deep breathing techniques, which are really good for when you're exercising. And if you practice those when you're well at rest, it's then easier to actually use that sort of information when you're starting to get really breathless. And it's learning which muscles to breathe with rather than your shoulders, which will get very tired, to breathe with your diaphragm. So, practice deep breathing when you're quiet and don't actually need it.
Just following on from the talk about exercise, I think during those pulmonary rehabilitation classes, you might get yourself on. They quite often teach you some of these exercises, these breathing exercises, and how to cope with those feelings.
There is a booklet that we produced, I think about 4 or 5 years ago, wasn't it, Sean? How to be in control of your breathlessness, which we've got on one or two of the stands on the corridor down there. It's a small blue book. It was written by Janelle York, Professor Janelle York, who we do quite a lot of work with on breathing techniques. So I think it fits in exactly with what you three have said, and it's readily available. It's definitely worth getting a copy if you've not seen it, and it has got a DVD in it which goes through the exercise. As Natalie also said, that anxiety is not a weakness. It's not a weakness of somebody's personality, etc. That it's just a natural thing to tell us something not right. But there are ways in which we can take control of that. So it annoys me intensely when people say, "Oh, and I'm not normally an anxious patient." As though that's some sort of weakness to beat yourself with. Just about being honest with ourselves. I hate the discussions where mental health and I can cope with anything. Well, good on you, but the majority of us can't cope with most things that life throws at us. So we look for help from each other as well. And you get no sympathy from me telling me you're not an anxious person or I'm a really strong person. Well, yippee, keep it together, because most of us don't have that armour in our case either. Anybody else on that one? It's a very common one. And I do like the idea, I know it's not a flippant one, I like what you said, Natalie, that nobody dies from being breathless. It's just that terrible feelings that you could do. It's a deep breathing. And as John said, it's prepare yourself. That's the beauty of exercise beforehand. It prepares you to deal with those things well in advance of it.
There is one thing I think. Just to add to what is said, but I think when there's certain patients with pulmonary hypertension of different other conditions like lung disease, which causes endless amounts of panic. So it's not just anxiety, it's panic, especially when they do certain activities. And I mean, going to showering, dressing. And the intensity with that particular group of patients is to use some medications to help relax, because you can actually take medications, some mild lorazepam, or there's a whole bunch of medications that can help with reducing that anxiety for those who are, will hit a panic state, which is a little bit worse, I think, than the anxiety, because it's a moment of not thinking you're going to survive. Because like Natalie said, you don't die from it. But when you think you are going to, I think that's the important thing we need to avoid. That's it.
Second question. Okay.
Now that Selexipag has been approved, can I come off my pump and go onto it instead?
Okay, so Selexipag. Selexipag's available. Guys on pump. Can you come off it?
There's $1 million question. Probably not, as a short answer, but it may be in exceptional circumstances that patients will be able to come off their pump and onto Selexipag. So Selexipag was a drug that was trialed, and so the evidence from the clinical trials is in patients who are relatively stable, but not as good as they would like to be and we would like them to be. So this was a drug that was shown to stop people getting worse, and it isn't a drug to be used in patients who are at the severe end of the spectrum or who are actively getting worse. So this is about keeping people stable rather than rescuing them. So I think we need to be clear about that. Obviously, it's going to be hugely attractive as a tablet versus either the nebulizer or a pump and all the complications that both of those have. But that's not often where we see it going to be used. So from my jigsaw earlier, it was tacked onto oral combination. So the NHS has commissioned it for patients who are on a PDE5 inhibitor, so sildenafil, tadalafil, plus an ERA, so macitentan, ambrisentan, bosentan, as a third therapy. And so there will be exceptional cases where the line has become so much of an issue and we need to get people off, but I think those are going to be exceptions rather than the general uptake of this medication.
Can I just add to that is that our colleagues in the US and some of them in Europe that have been using Selexipag for a lot longer have a series of patients who they have transitioned from IV to Selexipag, but they're very, very carefully selected. So it's people that are incredibly stable on therapy, who with all their drug therapies have brought their pressures down to pretty good low levels and are all on doses of much less or 20 nanograms per kilogram or less. So it's very small doses of IV therapy that are already very, very well supported. And there are 3 different groups that I know of that have actually run this in their patients, and the majority of the patients have been able to transition, but there still then are patients who have had to go back onto IV. And I think it's almost a bit of a lottery, is that if IV has kept you stable for a very long time, you run the risk of destabilising going onto Selexipag. So very selected cases.
And to add to that, which is really, really important, if I, as a clinical nurse specialist and your clinical nurse specialist, can give you a tablet that will take away your IV therapy, which is 24 hours a day, 7 days a week, 365 days a year, every year, then I would. This isn't a new wonder drug. It's a new drug in pulmonary hypertension. It's not going to be the answer to everything. And, most people who do well on IV, that are, successful in the way they treat, that their pressures come down, their walk tests are going up. Yes, the burden of the treatment itself is always there, and I'll never, ever, ever be able to understand it myself properly, probably, but I do know that that's the drug that's working and making you well. But always remember that if there's a tablet that I can give you, administer to you as a nurse, I would, and that's not Selexipag.
Yeah, I mean, I don't think I can add much more to what you've said, actually. I think my feeling is that the evidence is that intravenous prostacyclin is still the strongest, it's still the gold standard when you need it, and that this is not a replacement for intravenous prostacyclin. But I do believe there will be some people, for whatever reason, who might be, we might be able to transition to tablets. It might be that they haven't got up to a very high level at all because they're having either side effects or psychological effects of having the pump and the line. And if they're not up to a very high level anyway, it might be that they're better on a tablet. But that's a minority, I think, minority of people.
Yeah. Okay. What we're going to do, we're actually just going to give you 2 minutes break now, because while it's a question time from you to the panel, we've got some questions for you, which is actually, I want you to have your clicker pads, actually. Bit of a straw poll. It's a number of things that we as an organisation, just, I know the IT guys will be dead pleased I'm doing this because I should have done it before, but I'm just messing about with you, messing about with your mind. Okay?
He's teasing you.
I'm teasing you. So we're going to do, is it 4 or 5 questions? 5. There's 5 questions, so we'll do them, run after each other, and then we're actually not going to, I'm not necessarily going to ask you to talk about them either. It's stuff that we're going to take away as an organisation ourselves or use in other contexts, but it's about having this group together. And I have to use is it Prestige Green? Is that right? To start the time. So, first time at conference, dead easy one. It's a yes or a no. There's no maybe. Have you been here before or not? Okay? All right. So that's a good thread, a good third new. That's really good, because in the old days, what we used to get is people just keep returning. But I think this conference is good. It's a good mix of breakdown there. So that's good to hear a third, a completely new. And welcome back to the other 2/3. It's not that you're not welcome, but yeah. Next one. Yeah, so if you knew, then you're going to have to guesstimate this one a little bit, but there are a number of reasons. We've done survey after survey each conference, and what's the value of the conference itself. But this is to you again, so patient, not patient, husband, wife, I don't know, whatever, lover, whatever it is, admirer, 1, 2 or 3. No, you're going to pick 1, 2 or 3 and do as you're told. Please. What shall we be with 33%? All right. Oh, meeting new people, not that bothered, but I know, I mean, it is surprising, isn't it? When the lights go up as well, you think, oh my God, yeah. All right, that's good. Good. Yep, gaining knowledge. So this is the expertise. But it's also about gaining knowledge from each other as well. Don't forget, you lot are experts here by experience, okay? These are experts by education, believe it or not, the best of the British education system. But you're experts by experience, and it's together that we've made this dramatic difference in the last sort of 20 years. Next question. Right, so this is about social media. It's one of the things is that we want to know as an organisation. Lots of people have mobiles and laptops and iPads, etc. But what do you actually use it for? So again, fairly honest. That's incredible, because we did a survey like this about 5 years ago, and it was down. It was the opposite way around. It's the opposite way around with our membership. We've got to be careful here, and so this is people who attend conference use social media in this way. So as a strategy, etc., it's useful, this sort of stuff. But it's members of the PHA who attend conference tend to use social media. Often, clearly more sociable than other folk. Next question. Yeah. So this is just using it. So do you use it on that wider context to communicate with, say, everybody that would be here, or is it purely I use the social media to let family and friends know that I've just had something to eat, or I've had this drink, and here's a picture of it. Slightly sarcastic. All right. Oh, well, that's interesting. Good. Again, this is helpful. So is this the last one now? Is this number 5? I think so, isn't it? Yeah. Okay. Oh. Was that it? Well, they're messing with me now. I pay the cheque at the end of the day, mate. Oh, right, yeah. Can we play this one? Because we'll play it back to Paul Corries on this one. One of the things that Paul is doing for Natalie this afternoon, he's talking about transplantation. If you want to come to it, it'll be in this have you discussed, so this is a general discussion with PH or not, have you discussed with your family openly, not begrudgingly, about organ donation? Yes or no? Yes. No. So it's still quite high percentage of people find it difficult. It's interesting. Yeah, microphone.
So in the United Kingdom, for example, this question is going to change because, like Wales, England is now going to be where you opt out and not as opposed to opting in. So that's is a very interesting question. Will you be telling people I'm opting out when and I can say that from what I understand of it anyway, even though Wales has this opt-out policy, I don't think transplantation has gone up in any significant number because of that.
And that's true, because the reality is the law's changing, isn't it? I mean, one of the things that Theresa May has managed to get right, bless her, and she's had a busy time, is that the opt-out clause is there. The problem is that still, in an acute phase of death, unexpected death, when there is that discussion with the transplant team or whatever, they will still have the conversation with the members of the family. And if the family object, I can tell you now, there's going to be no retrieval team who will argue with the family saying, but Carl's active on the list, he's opted in. So, and if his mum and dad said, well, you're not having his beats, and we want all his beats, I don't know what for, but we want all his beats staying, then they're going to have that, because the family will not be second. And that's the reality of it, this open discussion. For God's sake, it's not morbid, It's one of the greatest gifts that we can give. We'll talk about what should we buy the kids for Christmas, and we'll spend weeks and weeks talking about it. What's the greatest gift you could, if you want it to do it, that's fine. If you don't, then that's fine. But just make it known. Did anybody else want to say anything?
I was just going to say, it's just the way that the question's phrased. If you've got pulmonary hypertension, you can also still be on the donor list. They might not want your lungs, but there are other bits.
Yeah, it's true.
There are other bits to be quite keen to have, so everybody can be on the donor list.
Yeah. Any word from the good doctors on either of these? No.
I agree totally. Actually, actually, my daughter, she wanted to be an organ donor, and I hadn't. I'd sort of hidden away from it, but I saw her do it, and so I sort of signed up for it as well recently. So yeah.
Good. Right, so well, anyway, they use some information. There's some more this afternoon about the organ stuff when Paul's involved in it, because the whole thing about organ donation is always a possibility for anybody with PH. It often isn't necessary, as is the thing that Natalie's going to be talking about with her surgical intervention. It's appropriate to some people, depending on diagnosis and response treatment. So, next question. Are you awake, audience? Yes, right. Next question.
Is the advice around pregnancy and PH still the same, or have there been any developments? Can you adopt a child if you have PH?
Right. There's some funny accents here, aren't there? I'm from up north. So it's a question around pregnancy. We usually always have this. The issue about pregnancy is, has it changed over the 20 years? Are we in a better position to talk about it, to act upon it? And there's a second part which we might go to as not about the potential for a PH couple, somebody in a PH couple or an individual to adopt. Have you ever heard about it? Who wants to go first with it? It's a sticky one, this. Wendy, you've got the mic. So, pregnancy, PH.
Yeah, so this is one of the things I was talking about our PH Education Day on Friday, is the advice still is for ladies with pulmonary hypertension not to get pregnant. The old figures that used to be banded around is that sadly mortality was between 30 and 50% if you got pulmonary hypertension. Things have changed in the recent era, and if you look at the latest statistics that have come out, is that mortality in patients with the idiopathic form of the disease, if they get pregnant, is 17%, which sounds a lot better. I will say that with a word of caution, because we're so good at actually pointing out the risks of pregnancy to patients that most of them have adequate contraception and decide not to get pregnant. And so the ones that do are very, very carefully pre-selected almost, and that then take that risk. So they're very, very well treated on therapy, and the majority of them are calcium channel responders, the ones that are a slightly different form of the disease. So I would say statistics will show that survival's a lot better, but I think it's very carefully selected, and still 17% chance of dying is really high. Mm-hmm. And I think the decisions need to be made with the individual, because everybody is very, very different, and counselling from a high-risk obstetric physician. And it's much better to consider before you get pregnant rather than rock up and say, oh, well, I just thought I'd give it a go. Because some of the PH drugs also need to be altered if you're pregnant, because they can cause birth defects. And just on the second one, just in case I don't get the mic back, is that we've had several patients who have adopted. And I think the big questions that they ask is, how well you are, how stable your pulmonary hypertension is, and if something sadly did happen to you, what kind of support would there still be for the child, the other parent, and be able to bring up the child, with lots of support and safely. Mm-hmm. So it can be done, and we would support people in adoption and surrogacy.
John, can I ask you to?
Yeah, I mean, I would agree with what Wendy's said. I mean, our own experience is that those figures are a bit out of date, and that the outcomes are better, definitely, but 17% is still a very high risk. And so our advice is, again, against becoming pregnant, but if, and it's your decision, if you decide you really do want to, then we will support you, fully, and go all the way to support you through it. And we have done successfully in quite a few cases, but it's a massive decision. It really is a massive decision, because the risks are very high.
Yeah, just to add to what Wendy was saying about the medication, that is part of a crucial planning phase. So if you really do want to pursue it, then it really is important you have a conversation at your centre to understand all the risks, but more importantly, because your medication will have to be altered, and you might be well because of the medication you're on, or that's at least a part of it. And if we were to make changes to it, there's obviously potential that you may be less well on what we can give you, because we cannot give you, for example, the endothelin receptor antagonist. We can't give you those in pregnancy. If you're on warfarin, you can't be on that. So there are other medications that you literally cannot be on for reasons that it may damage the unborn child. So it's a serious conversation. So bear in mind, not only about getting pregnant, but also contraception. Have those discussions as well at your centre to make sure that things don't happen accidentally.
Anybody else?
The only thing I would say is that if you actually find yourself pregnant, and I'm not talking to the men in the audience, obviously, but if you did find yourself pregnant and there is one key thing. Yes, there are drugs that might have to change. We mentioned that. But 2, you could clinically get worse during that pregnancy. 3, they may have a long-lasting effect on your long-term outlook in terms of pulmonary hypertension. It's not as simple as the here and now with pregnancy. But ultimately, whatever you do, if you find you're pregnant, you must let us know. Because that's the key, because it's not our job to make a judgment. We're not here to make a judgment. We're here to look after you. And that is as much as important a fact in our care is to look after you and not to take you and go through that journey with you. And we've done that. Fortunately, not for many people, because obviously we don't want you to be in a position where your health gets worse, but please just make sure you get in touch with us as soon as you can if you do know.
While we've got the opportunity, I wanted to briefly touch on contraception. So I'm sorry if this is embarrassing for anyone. 2 methods, one of which should be a barrier. Having a coil fitted or something like that should be done in a hospital. And the reason for that is if you have pulmonary hypertension, you're a little bit more at risk of a faint. And a faint can be difficult to come round with if you're not particularly stable. So it's important that this is done in hospital if you have a coil or anything like that fitted. In terms of actual oral medication, what do you think? It's the mini pill, the microgynon. Yeah, it's far and away the best one to be taking, but it's important that you take them consistently. Sorry, which one? Yeah, not combined ones. Any questions on contraception?
Well, can I just add into that one as well, Natalie? Because do you want to? Yeah, Neil, good, because you're part of the team.
I'm part of the team for this, but I've been working closely with the PHA in the production of some materials which are going to be out in the not too distant future with some really helpful, good factual advice about contraception. So look out for those.
It covers things that, like Natalie said, etc. And if I can get our production team in order and get them going, we're not far. I mean, we're literally talking probably the next couple of months that should be ready. And then the other thing that we are doing this year is it's on by demand, and I hear what you're saying. I'm a clinician myself, but you know the reality is that 20 years ago, the best advice for mother survival was termination of pregnancy. That was without doubt. It's different now, and we will all take risky decisions. As everybody said, our job here is not to judge anybody who makes a decision that we would consider risky, but we will support you, and as an organisation, as PHA, we would support that. And I don't know a clinician in the UK that would not support a patient who was pregnant and decided to continue with that pregnancy. So one of the other parts of the materials that we will produce towards the end of the year, and I know we'll be sticking our necks out on this, is telling the stories of people who make the decisions to continue to be pregnant or make the decision to get pregnant, because that's part of the story that has to be told these days. And you know, the mortality figures are high, and it's not about encouraging people to do it, but we cannot just say to people, you cannot get pregnant, because that's not true. And some people make decisions based on very strong, either personal, maternal, even cultural and religious reasons. It's very important to them. And so long as the consent is there and the understanding is there, then, you know, we are pushing the boundaries here. But the experience in Sheffield with pregnancy is helping to change the culture thing. And I think also at the Brompton and in different areas, it is slowly changing, thankfully. But it is still high risk. We've had about 40 pregnancies in Sheffield. The majority of those have gone successful, but they've been hard work. But we've had deaths, and that's deaths of young mums. So it's not easy to do, and you think, well, that could have been avoided. But You know, it is a really uncomfortable area, but it is one that has to be addressed. And these other areas, like we were talking about with adoption, surrogacy, are possibilities. And we as an organisation will tell what those possibilities are. We're not advocating one way or another, but we'll not be a silent voice and just say, well, you've got to listen to the healthcare professionals. You're experts by experience yourself, and we learn from other people as well. So, you know, when we take risky decisions with our own health. Yeah.
Okay, sorry, the other thing I just wanted to say, because we've had an experience recently in our centre, is we get all the adult specialist centres get youngsters transferred through from Greater Ormond Street. And one of the first things we have to address with them is their sexual health, their contraception. And the thing is, it's a bit late. So if you are a parent of a child, the wrong time to find out that they've been experimenting sexually or are sexually active is when they're pregnant. It needs to be raised really when they're still very young. You need to talk to them about the responsibilities of parenthood and about contraception, and preferably before they actually come to the specialist centres. We will address it with them. There's no doubt about that. We will address it with them. But it can be tricky. If you've grown up with your child, or your child has grown up with pulmonary hypertension, it is so easy to continue to see them as your child. And actually, the young adults are much earlier these days than they used to be. So, you know, it's worth bearing that one in mind. If you're embarrassed about raising it, if you really don't want to, if you don't know if your child might be kind of, you know, going in that direction, then you need to talk to specialist help about it if necessary. It is really important that it is raised in good time.
Okay.
Hello? Is this work? Yeah, it's working. We know an awful lot about the risks and implications of pregnancy in females, but how does it affect the males who are on current medication and, you know, fertilisation and the egg, and, you know, does it affect a fetus? Will it affect how it develops?
The pH medications themselves won't affect if the man is taking them. So in that respect,
In that respect, they can carry on breeding.
carry on.
Can you carry on what? Breeding?
That's fine.
As much as they like to.
The only thing I will say is that in the early days when we used Bazentan, there'd been some data that came out of giving really high doses of Bazentan to rats, and it decreased their sperm count. So back in the very early days, we used to warn our young men that might want to have, or older men that wanted to have a family, that this might happen. And so actually some of our patients then went and saved sperm. But actually, I think in reality, it doesn't really affect humans. And these poor little rats were given huge amounts of drug. So actually, it's absolutely fine. But I think some people, if they remember all the way back, might have heard something about infertility. But it's only in rats that are being force-fed Bazentan.
No, I think that's John. Anyway, thank you for that one to say. I mean, watch this space about the contraception stuff. I mean, one of the things we're going to do as a survey is actually find out when people take it with pH. I know the advice is two contraceptions, two forms of. I mean, there's a lot of debate whether people actually do use two forms of contraception, whether that's true or not. We'll not do a questions and answer here, but it is important. I mean, that's the best advice, but we often don't do the best advice, I'm sure.
Can I just add to the pregnancy thing? Because we're all talking about pregnancy and contraception, but for the lady in question, she also has to make a choice whether she goes through with that pregnancy, and we've not addressed that. You know, and sadly, some women turn around and say, "I don't want to go through with this pregnancy. It was not meant to happen," and then you have to go through a termination. And even those patients or people, young ladies with PH who become pregnant, they still have to make that choice, and that choice will always be raised with them when they see the gynae doctors and the PH doctors in the joint pregnancy clinic. Do you want to continue with this pregnancy? So you have to make a choice, or ultimately you make the choice. But you know, that's another key thing we've not mentioned about going through the path of termination, because that in itself carries its own risk. usually, generally if it's in an early stage of the pregnancy, just take a tablet and then, you just naturally lose the young fetus. But sometimes it becomes an operation, and then the risk of that has to be balanced against whether you keep the child or not. So there's more to this, and you know what? If you take away PH and you put any other condition there, you're all facing the same thing, and we should be looking at what other patients with chronic illness do to manage pregnancy as well, because apart from the risk to life, if you like, or deterioration, there's it has an emotional impact, which I don't think we've really addressed with you. We've been very black and white, tablets, risk, but there's a huge emotional, and some women will find it really hard to get over that they were not allowed, or they felt they couldn't continue with the pregnancy, and I've seen that, and it hurts. So, this is a huge area of not just whether things have changed in the last 20 years, because they haven't really, apart from statistics.
Okay. Next question.
Hi, don't pass out, Wendy. It's about exercise. When I got PH, I was actually training to do the couch to 5K, and it was sort of like in between training that this got discovered for me. But listening to your exercise, I would love to get back to doing the running because I enjoyed it. But for me, it's like a huge trigger because it's like how I found out I had PH, but also I'm on the line as well. So I wasn't sure if we could do it or push ourselves, and obviously I'm trying to lose weight to get transplant assessment, but I'm very active. I've got a family of 3. I don't sit down much. I watch what I eat, but my weight does be an issue, and I feel I should be doing more exercise, but I don't know how far to push it with being on the line.
I think exactly as John said this morning, you start off being able to walk continuously, then build it up so that you can walk at a bit faster pace continuously. I wouldn't say somebody suddenly start going, and I think probably couch to 5K is quite good if you haven't got a chronic disease, but I wouldn't push it that much, but just start off gradually. And I personally don't think jogging or running is very good exercise because I can't do it. Because I probably do need to do the couch to 5K. But I would say, continuous walking at a good pace is always the very best exercise. And then if you're finding that easy, then go and do a bit of running. Yeah.
I was training, I stopped for 2 or 3 weeks and not on holidays. I went to go back and I couldn't run.
Yeah.
I couldn't do anything. And I got part of it.
And what we are seeing more and more as people are using fitness technologies is that they're tracking their steps, they're tracking their speed using Strada when they're going for runs. And what we are doing is picking up some of the patients probably a bit earlier in the disease, the ones that are really very fit, who do go for runs, and they're noticing that their run time is getting longer and longer. We had a lady recently we did a video for one of the awareness campaigns, and she'd been back to her doctor on the Strada, sort of showing that she was coming down, but still, she was much fitter than I was, or I am. So actually she had a good level of fitness, but what she was saying, this isn't my normal. And went on to have an ECG and be investigation and picked up pulmonary hypertension. So I think more and more we're picking it up on the sort of the fitter people as well, who will monitor them on apps. So I think at any stage, whenever you pick it up, once you're stable on therapy, it's certainly back to rehab.
I think it just shows again the importance of what's available within a specialist centre is you need that advice readily. You need it from a physiotherapist. You need qualified people to help you, because for you it's absolutely crucial. I mean, there's the psychological thing that this is when I discovered, but then to get to a point where potential transplant might be an opportunity for you, is that you've got to come within a certain BMI, and we just don't have those facilities readily and at a centre, and it's a disgrace to the NHS that people like you are denied that opportunity. It's an absolute disgrace, and it's cheaper. Physio is cheaper than often one individual person's drugs bill, but we just don't get access to it. And that's what I was saying earlier about much of the work that we're about now will be about ensuring these centres are robust centres and meet the very needs that you've got, because you're almost like a voice in a wilderness. I mean, Wendy, with all respect, is not the best person, and I mean with all respect, Wendy, to ask about an exercise programme. And I just mean that with all respect, 'cause it's not your professional area of expertise, is it? Neither is mine, but you know.
I think probably the initial advice is the same sort of advice that Carol gives that we would give to everybody. I will say we have an exercise physiologist who's now setting up a new research programme who'll be working using cardiopulmonary exercise testing and developing individualised exercise programmes for our patients. So although we sadly don't have a physio at the moment, our exercise physiologist is going to be working on a new research project. The other thing that I will say is if you've got a physio in your centre, they're very good at being able to assess the patients and then send them off to the local centres. But if you live 300 miles away, you're not going to want to come to the Hammersmith every week for an exercise programme. So it's really, I think, assessing them and linking people in with the most suitable local service.
And that's what people like the physio in Sheffield's doing, and I know the idea with the Brompton and see if geographically a similar sort of process. So that physio doesn't necessarily is the one who does the programme, but gets you access, the key to something local, and does the donkey work to find out what is available local to you. Final words, final 2 words.
Yeah, no, I would say that, well, I obviously don't know your case, but I would have thought that should be your goal. To do that, and you just need, what you need to do then is just start off slowly.
Yeah, that's fair enough. It's just, I'm scared to do exercise in case I live in the middle of nowhere. Hospitals, you know, that's a bit like, by the time somebody finds me, it's too late.
Have you been to a rehabilitation class or?
No, but I'm involved with the local leisure centre. I do admin for them for work, so I'm going to see. They have mentioned things going on there. So.
Yeah, I think being in a safe environment where you're being like supervised, maybe on, you know, whilst you're walking, maybe on a treadmill, just walking a bit faster, maybe with a bit of a slope, just with someone around will give you the confidence, and don't do it too much too soon. Just gradually, but with someone there, and then it'll give you the confidence. And then I would say go for it. You know. There's no reason. It's safe. You know. I mean, and if you're monitored and to start with, to give you that confidence, and people are helping you all the way, there's no reason why you shouldn't do it.
Yeah, just to sort of add, then, I mean, the ladies alluded to this couch to 5K. If people aren't aware, what that does is, for someone who just sits on the couch all the time, over an 6 to 8 week program, gets them the ability to run 5,000 meters. So that's what it's all about. But it does it in a very structured way. So day 1 on week 1, you walk for 2 minutes, and then run for a minute, and then slow down to a walk again and build up. And it's really, really slow incremental change. And that's exactly this. Whilst that might be fine for general population, that might be too much for the PH patient. But these programs and the physios can basically tailor a program exactly to you and your specification and where you are, that exactly mirrors the idea of the 5K to get you to your goal. So it's the spirit of it, without necessarily getting everyone to run 5,000 meters, but ideal.
Okay, I just wanted to share a tip. As a lifelong non-exerciser, I now exercise 5 days a week. And how I did it was by establishing the habit. And I think everybody has really good intentions. You see that on the 1st of January every single year. This year I will exercise. And we all intend to start, and then very often we do start, and very often, for the vast majority of us, we just don't keep it up. It gets too tiring. It's establishing the habit. And the way I did it was 5 minutes a day for 3 weeks. And anybody could do 5 minutes. You don't have that feeling of resistance to it. So 5 minutes a day for 5 weeks, 3 weeks, 4 weeks, 5 weeks. And then I increased it by 1 minute a day until I got up to 15 minutes. And that's where I am now. So really and truly, my tip is concentrate on establishing the habit. Once you've got the habit of exercise, you can start increasing the frequency.
Just hear what you're saying is about confidence first. There's something psychological that's a barrier there as well. And that's often for many people with PH, is having the confidence to try and get back to a normal existence, because in the past I found myself stuck there and I couldn't get out of it. So it's that's the issue. Right, can we move on to next question? Because Sue's holding a breath there, so I've seen her. Go on.
Does stress and anxiety make the symptoms of PH worse? And if so, why? How can I do something about it?
Yeah, I mean, we've just been touching upon that. I know the difference, but why is it that stress and anxiety make the symptoms of PH worse? Well, what is there a physiological thing that's going on there, doctor?
Well, I'm just thinking, when I was, building up to give my talk, then I might have seemed relaxed, but my heart rate was going up because of the adrenaline that was being released, and I was feeling a bit sweaty, and my respiratory rate was going up. I was feeling a bit uncomfortable, and adrenaline, which is the hormone that's produced when you're feeling anxious, and stress can also cause the airways and the blood vessels to narrow, and so it's not surprising really that when you're feeling anxious, it's going to make the symptoms that you get with pulmonary hypertension worse. Really, yeah. I mean, I was feeling a bit of it then just for my talk, and you can imagine how it's amplified if you have pulmonary hypertension.
That's just the anxiety of worrying how Ian's going to introduce you, John.
Yeah. What he's going to say next.
Yes, yeah.
And one of the extra bits for like long-term sort of stress is that your cortisol level goes up. And when your cortisol levels are high, you tend to retain more fluid. And cortisol places a huge demand on a lot of the organs of your body. So it's high cortisol levels, high stress levels all the time, as well as the adrenaline that gets released when you're about to be introduced by Ian. So it's controlling both of those, and I think we've already talked about it, getting help through someone like Anxiety UK, who can signpost you to local places, and things like mindfulness. But whatever suits you, but actually don't wait before you actually ask for help. It really isn't a shortcoming for anybody, because we know that a huge amount of patients with pulmonary hypertension and any other chronic disease have high levels of anxiety and depression, so it needs sorting out.
And just as well as assurance, it's not just people with illnesses. Doctors and nurses live with high levels of anxiety and uncertainty, believe it or not. I mean, we do. So there's nothing special about you. There's nothing special about us. As I said before, no apologies. I think it just needs to be part of our normal narrative. If you're in clinic and you're speaking with Carl or John or whoever it is, that you just naturally mention it. The Emphasis magazine usually carries some sort of article on anxiety. Give no apologies for that, because it's a huge part of living and living and getting on with PH. Not just in the individual with PH, but also with the relatives and the family members, etc. It's part of being human. It's a human frailty that we've got. We need to just support people with it. Next question then. Wake up.
I attend one of the specialist PH centres in the north of England. I believe it's an excellent centre, but how do I know if it's as good as the other centres in the UK or even in the rest of the world?
Ooh. Natalie, you just retired. Natalie, you just retired from one of the UK centres. I think there's a number of things here, not to forget the national audit.
Yeah, the national audit is the main, objectively, if you read the results for the national audit, there's a series of targets that each of the specialist centres have to meet, and you can see how well each of the specialist centres have met them. I can tell you right now that all of the important targets have been met by all of the specialist centres. Yeah, it's interesting because each of the specialist centres are generalist, but they also, some of them have some specialisms within them. So, for example, the Brompton is famous for its congenital heart. The Royal Free is famous for looking after people with connective tissue disease. Papworth is increasingly being known as the thromboembolic centre. But we're all generalists as well, and we're all experts in all aspects of care of pulmonary hypertension. So how can you tell which one is the best? I think if you are at one in the UK, then you're probably at one of the best centres in the world.
Yeah, no, I totally agree. Or the national audit is a fantastic sort of idea, and more recently, it's been very transparent in these standards that have been set. comparing them between centres, and it's very reassuring to see that there's nobody that stands out one way or the other. We are all doing a very good job, I think. Yes, and that's also, we had a peer review from NHS England with the quality surveillance team, and again, there were a few little bits and pieces, but nothing that stood out, and all the centres were felt to be providing excellent care and were safe. So I think the lady could feel very reassured being in the north of England, and anywhere else can feel reassured as well with their centre.
And just to add to what colleagues have said, the targets that that the centres have to show that they meet have been at least scrutinised by the PHA, and the PHA as a patient group have defined those that are the most important. So as you go through the report, you can see which are the most important to the PHA. One of my other roles is on a national group, and on one of our work streams for the next year is looking at the standard specification and standards for those centres and the goals and targets that are going to be reached, and that is being very much led and driven by the PHA. So you as the patients are determining what standards and what targets we as centres need to be meeting. So it's very much a collected sort of project.
I'll add my bit as well. It is just to say that actually the UK Pulmonary Hypertension Service network is the envy of the world. You go to places like America where everything's supposed to be rosy, but actually almost anybody can treat pulmonary hypertension, which means that non-specialists are not necessarily optimally managing their patients. And it's the same throughout a lot of other countries in Europe. We heard on Friday that a paper that I've done with some girls from Canada and the US that looks at pulmonary hypertension centres throughout the world is actually going to be published, which is quite good. And what was really sad with that, when you looked at it, and this was responses from 37 different countries, of people who designated themselves as specialist centres, who answered the questions, over a fifth of them didn't even have a nurse in the service, let alone any other support teams like pharmacists, physiotherapists. And it was just single doctors trying to manage pulmonary hypertension on their own. And they're not, they certainly are not scrutinised like the NHS England scrutinise our centres. Mm-hmm. So I think a lot of work needs to be done globally. And the patient charter that I was talking about earlier on, part of that is access to expert centres, defined as expert by the guidelines from the European community.
Just to add on to that, I think if I were a patient, then I was in the south, and then I had to say, well, I'm moving up north, where would you send me? I would say anyone, Sheffield, Newcastle, Scotland. Because what I feel is that within the UK, we're not a closed shop, by the way, because it all sounds like we're all like mafia here saying, yeah, come to ours, we're going to be the best. But, but what I'm saying is that each of the centres, even though we have differences, the fundamental model is there. You have a consultant, a nurse specialist, and now a pharmacist, and hopefully add-ons such as physiotherapists, who should all be part of the team. So there is a core element that is the same. It's all about advanced knowledge of the condition and the medicines that we give you. And that is key. And not also that is about how you, through experience, how how the trials and tribulations that you will face, and how we can help manage with getting the diagnosis or moving on with the diagnosis, or even when things are getting worse. Because that's the other thing we've not talked about, is when things get worse, that's another element of pulmonary hypertension that has to be managed and looked after. And there is not a pulmonary hypertension centre in the UK that I would not say you cannot go to. You might even get fed up with us, I don't know, I'm sure some people will say they do, especially when their football team is not doing as well as they should do. But fundamentally, the centres mirror each other.
Sorry, it just occurred to me. The outreach centres, some of you will be regularly attending places like Leeds or Hull or Plymouth or Norfolk and Norwich or wherever. Just to reasure you, you're asking about the quality of the centres. The outreach centres The physicians and specialist nurses travel from the specialist centres to go to the outreach centres, are engaged in very active education programmes with them. There's a lot of interaction, a lot of education goes on, and a lot of close communication between the main specialist centre and the outreach centre that sees patients on their behalf, or with them sometimes. And they were all featured as part of the peer review as well. So they were all reviewed by NHS England and by other members of the pulmonary hypertension professional community.
Just one of the, just to talk about the peer review, and this is something that we get becoming increasingly concerned about. The peer review, just to reiterate to people, was it was 2 years ago, last August, that peer review started in the UK. So it was where all the PH centres were reviewed by peer support. So maybe, I can't remember who came, so each centre was examined, its function, its paperwork, everything that was looked at by the peer group within the UK. What we haven't had at the moment, and we're now becoming increasingly concerned as an organisation, is NHS England have not published the final report on that. We're finding this really quite discerning. We've got a meeting with them at the end of the month to find out from NHS England why they have not published that report. And not wanting to be, a drama queen, etc. There is always risk at expensive services in the NHS of fragmentation, etc. And I'm not saying that that's the case, but we've heard one or two things recently on the grapevine about fragmenting specialist care, because it costs a lot of money. But under my dead body will it fragment the service that we've built up over 20 years. And we are concerned that the final report for the peer review has not been published, because it's on the basis of that we will use it as a launch pad for the future development of the service in the next 20 years. And we cannot understand why it's not been published. Peer review must have cost the NHS a couple of £1 million. Now, I don't have a couple of £1 million to spare, and if we did, I could transform every single centre in the UK. So when we meet with them on, I think we've got a day 30th of May, when there'll be 3 people from NHS England coming to explain to us where the report is. And it will be very interesting. And if we don't get it, then there'll be, that's one of the times when we'll be coming back to you as our members and maybe starting to write to your MP and saying, what do you think you're doing with the service, the PH service? Because it's highly effective. We've got a drugs bill of only £40 million a year. The CF Trust are looking for a new drug that's going to cost the NHS £950 million per year for the new drug, and you're giving them all the leverage that you can. So stop taking the mitle out of this group and this group of people, because they deserve better. And that's what we're about. Julie.
I was talking around the table this morning with some nurses and other patients, and I think the bottom line anyway from that question what you said, and we need to be involved if they don't give you these results, is we as patients feel the safest.
Absolutely, yeah. So we know that, we've got that information, so just bear in. Now we're going to finish. I'm not quite sure what the next question is, but it's bearing in mind what I've just sort of been alluding to. So I've got a question to you, and I'm not sure if it's the next person who asks this question, so I'll ask it myself to each of you. You've got 2 minutes, okay, to answer this question. And we'll start with the Welsh constituency first, because you'll not have a lot to say. If I was the health minister, and you had 2 minutes to tell me something about the future of the PH service, what you want, what are you going to ask for, Mr. Harris? Can you give him the microphone? So you've got 2 minutes with me, I'm the health minister, or if it makes it more comfortable, your fairy godmother. And you can have anything for the PH service that you want. What do you want?
So what I would want is equal access to medication, because that's not happening still in England and the rest of the UK, unless you're on a suitable candidate for a transplant. I would ask for more nurses so that you can have more quality nursing time, so that it's not a constrained service, because the services are going to expand with the balloon of treating chronic thromboembolic disease. I think that's going to be a huge impact on resources and what patients are going to need. I think what I'd like to see is that every centre got a designated pharmacist, of the designated physiotherapist and access to proper psychology services.
Okay, that seems reasonable. Anything different, more Wendy, different?
Yeah, I think Carl's just completely said my wish list. The only thing that I would add to it is a bit more office space, because as our service has grown in the NHS, our office space hasn't, so it's just more and more people all squashed in. So I'd want absolutely everything that you wanted, plus a nice place to be able to work. But we get used to living in cupboards.
This becomes more difficult along this way, doesn't it?
It's meant to.
So I think I would want to guarantee the security of the specialist centres to remove that threat, because patients with this condition need experts to care for them. So that's number one. And number two, we need access to all the therapies that are currently available worldwide. There are a few that other countries can get that we still can't get here. And also an acknowledgement from the NHS that actually the cost of delivering therapy isn't just the price tag on the medicine, but actually all the nurse time, pharmacy time and infrastructure behind it to support and make sure patients can, there's a phrase, medicines optimization. Basically what that means is for us to help you get the best out of your medicines. So that isn't just the cost of it, but that's all the support, making sure everybody understands what they're doing, understands why they're doing it, and to really get the best out of their treatment. So that would be an investment in infrastructure to support best delivery of the medicines.
It's getting really hard now, isn't it? I'd like to sort of revolutionise the way we sort of deliver care, and I'd like lots of money to modernise the service so that I think too many clinics, people travel a long way and don't perhaps get too much out of clinics. I'd like to develop more one-stop shops where people come along, have all their investigations, and then discuss it with a consultant. And then in between, maybe use more technology, so sort of Skype clinics, phone clinics, things like that, to so that people aren't travelling so much, aren't spending so much money, and we're just getting more up to date. So I think some money to get into the 21st century, I think, and also a physiotherapist in every centre for exercise.
Mm-hmm.
Okay, see if I can come up with something. So I'd like to see a clinical psychologist in every centre and designated for pulmonary hypertension in the specialist centres. I'd also like them to come on outreach visits to the outreach centres. I would like to see more funding spent on specialist nurses. I think at the moment we've all got far more than we can handle. And I think in terms of the number of patients in a centre per nurse, that needs to be brought down so that we can give more specialised care, be proactive about contacting patients, making sure that patients are feeling safe, competent, cared for at home, all of that kind of thing. I would like to see education for PH professionals. So for the nurses and the doctors, I'd like to see a structured programme of education that takes them all the way through from baby specialist nurse to a competent nurse consultant, and to have that available to every specialist nurse that would want to do that. I think that would be really important, and for the pharmacists and for, other groups as well. And last, on a personal thing, I would quite like it if the patients that have to attend Papworth that come from a long, long way away, because we're the national designated centre for pulmonary endarterectomy, I would really like it if we could put relatives up in a nice hotel, which at the moment we just can't. And I think that would be fundamentally something that would be a wonderful thing to be able to do. So that's what we'd like to see.
Right, greedy people. Now, before we just break, can you throw your rotten eggs and tin tomatoes at the group here? After lunch, there's a few things. There's some more breakout sessions, but we are meeting as well in here for those who want to. There's Paul Corris and Natalie at 2:00, I think it is, whatever time it is, in here to do the transplant and the PTE stuff. It will be filmed, so if you've got a desire to do one of the other sort of sessions as well, feel free to do that. But we wanted to capture it for filming for future and it'll go on the lifestyle website. everything that you said today is filmed as well, ladies and gentlemen, and it will be going live on the website. Well, it'll be going on the website next week. So just hope you got it right.
Are we not live streaming?
Eh?
We're not live streaming.
Oh no, we couldn't do that, Carl. No. No, we just couldn't do that. Not with people like you talking. It wouldn't have been safe. Yeah, and we're going to use it in different formats as well. So back here. Try and find your times out for your breakout sessions, and then this evening, the dinner. I look forward to seeing you there. I have bought a special shirt for this evening. And so I will be specially dressed for this evening. Are you dancing, Carl, tonight? I know you've been a bit injured, but he's well known for dancing. So we look forward to seeing you. And I think it's been a good morning. Thank you to the panel for taking that. You didn't know the questions, did you? And they were okay. You've done well. And I think the way that they've approached it, some really good, simplistic, but really understandable presentations, which sometimes is actually quite difficult for healthcare professionals to do because it's a different audience. So, many thanks for that. It's been a real joy to share the stage with you this morning. Okay? So appreciations to everyone.